Hi, this is Pat Taylor from Faces and Voices of Recovery, and I want to welcome you to today's webinar, Why Living in Safe, Sober, and Peer Supportive Environments Matters in Recovery. This is the first of a two-part series, and on behalf of Faces and Voices of Recovery and the National Alliance for Recovery Residences in Oxford House, we're really pleased to bring you this webinar, and we think it's a critical topic, and having a place to live is something that truly matters for people who are wanting to sustain their recovery for the long haul. Now, we know that 2 hours is a really long time to stay on the phone and to watch our webinar. We really appreciate your taking the time from your busy life to join us. Hopefully the topic and our terrific speakers will help keep you engaged over the course of the next 2 hours. I wanted to go over a couple of technical issues. If you're looking at the web screen where you can see the PowerPoint, you'll also see an area called Q&A, and that's the place for you to send in your thoughts and comments during the webinar, where we've asked each of our speakers to make their presentations, and at the end, what we'll do is go through those questions and work to answer them, and if we aren't able to get to every one of your questions, we will be able to follow up with you independently. I wanted to please remind you to put your phone on mute. That really makes a difference in terms of what we're doing. And underneath that Q&A screen on your website, you'll see something called Files too, and there are a number of documents there that you can download and refer to after today's webinar. I want to make a special thank you to all of today's speakers. We really appreciate the time and all their commitment they've made to making it possible for people to have a safe place to live and a supportive place to live in their recovery. Today's webinar and resources will be posted on both the Faces and Voices and NAR, that's the National Alliance of Recovery Residences websites. We've had tremendous interest in today's webinar, which I think reflects a growing understanding of the critical connection between having a safe place to live in recovery. So please feel free to pass on the links and join the discussion moving forward. There's been a lot of work done in this area, but there's much more ahead. So we really look forward to working and collaborating with you as we move forward. It's been a great pleasure for me to work with Jason Howell on this initiative. Jason is the new president of NAR. He served on the NAR board since its inception. He's from Austin, Texas, where he founded the Texas Recovery-Oriented Housing Network and has particular expertise in advocacy issues. So Jason's going to kick us off with an overview on recovery housing. Please remember to keep your phone on mute. If you dialed in, it makes a huge difference in terms of this experience. And we also want to make sure we let you know that we are recording today's webinar in order to share it with others moving forward. So, Jason, let me turn it over to you. Jason Howell.
Thanks, Pat. First of all, you can see that we have a really full agenda today. And just as Pat mentioned, you can add your questions there in that column to the right. Towards the end of the presentation, we'll be answering those questions. So as those questions come up, definitely type them in. So we thought it would be best to frame this webinar with an overview of recovery residences. And let me start by asking the question, where do peers live in recovery? And the answer is recovery residences. These are the sober, safe, and healthy living environments that promote recovery from alcohol and drug use. At a minimum, they all provide peer-to-peer recovery support services, but they can vary in service type and intensity. And we can plot these different types along a nonlinear spectrum that we call levels of support. So it's important to remember that all recovery residences are based in the social model. But as we move up these to the higher levels of support, you can see where the medical model is integrated to varying degrees. They've actually been around for quite a long time. Peers have been living together and supporting each other in recovery for over 170 years. We can trace recovery residences back to the mid-1800s with the Washingtonians. A century later, the recovery residences manifested in the form of AA homes. There were a couple of iconic houses, Pioneer House and Hazel's Den, which eventually became Hazelton. And we also see, in this time period, therapeutic communities form and the foundation of the Association of Halfway House and Alcoholism Programs. Moving into the late 1900s, that's when the social model started becoming articulated and well-defined. This is when Oxford House was incorporated. And when we started seeing providers at the local and regional level coming together and organizing, working together, developing coalitions, and this could best be seen during this time period in both Georgia and in California. By the early 2000s, we start seeing this growing body of research. Part of that research is why Oxford House is now listed on the National Registry of Evidence-Based Programs and Practices. And in, in 2011 is when NAR, or the National Alliance for Recovery Residences, was founded. NAR is a group of thought leaders across the United States. As you can see, the states that are kind of highlighted that yellow gold color, those are our affiliates. And the ones that are highlighted in blue are areas where providers are coming together and starting to form an organization and will be applying for official affiliate status. Early on, NAR knew that we had a nomenclature problem. I mean, what do we call these houses? We wanted to stay away from misleading language. Transitional housing, that really doesn't describe what people in recovery need. I mean, someone in early recovery needs to be focusing in on their recovery and deepening relationships in the community within the household. So transitional housing is not quite right. And halfway house, halfway to what? Plus the criminal justice system has used this term to mean something else besides recovery residence. We've got some great broad language that we considered. Sober house, that's a great word. Supporting housing, that's another great word, but we weren't really able to use that and to create this comprehensive language. And on the other end of the spectrum, there's some very specific language. Therapeutic community, extended aftercare, Oxford House. These are all very specific models of recovery residences. But NAR wanted to develop this comprehensive and standardized language, and that's why we started drifting towards the word recovery residences. Recovery being that process of change, and residence is a place in which one lives. So a recovery residence is where peers learn to live recovery. Now, we all know that as someone moves through their recovery process, our needs change. From a service level, those needs change. So with that in mind, NAR looked across the United States and was able to identify 4 distinct models, or 4 different types of recovery residences. And we say that they're on a nonlinear spectrum because the concept isn't that someone comes out of acute care and then moves into 3, then moves into 4, then 3, then 2, then 1, because it's much more person-centric. What does the individual need at the time? And they can be placed in the level of support or choose the level of support that's right for them. So, distinguishing between the recovery residences, one major way that we can do that is by looking at what services are provided within the home. As we've mentioned, all recovery residences provide this peer-to-peer recovery support. And as you start moving up to the higher levels, you start seeing life skills development as well as clinical services to varying degrees. The other way that you can distinguish between recovery residences is by their staffing model. So with a level 1, that's where we see a peer-run house, and the leadership is democratically elected. Once we get to a level 2, there is a resident, a senior resident, that is appointed head of household. So that's your house manager, house mother, house father. Once we get into level 3s and 4s, that's where we definitely see a robust staffing plan. We have supervised staff, and because in level 4s, we start seeing clinical services provided on site, that's where we start seeing licensed providers. So the question is, how many are there? And the answer is we're not sure, because not all recovery residences are affiliated with one of the national organizations. But we can look to these national organizations to get a sense of how many there are out there. So we looked at the Treatment Communities of America, which was formerly known as Therapeutic Communities of America, Oxford House, and NAR, and we generally know that there's around 3,700 recovery residences throughout the United States, which is about 15 recovery residences per million. I think a better question is, so what's the need? How many recovery residences should there be out in the world? Well, we know that 8% of our greater population should be in treatment, but unfortunately only 1.5% actually do receive treatment. So let's focus in on that 1.5%. You know, some could argue that if this is a chronic illness and we need to be supporting someone for their year for the best outcomes, maybe 100% of those individuals need to be in a recovery residence, but that probably is even beyond a stretch goal. So let's start with a baby step. Baby step being, say, 10%. So if 10% of the 1.5% that receive treatment, either in a clinical setting and or through mutual aid and self-help, if only 10% of those chose to live in a recovery residence, how many would we need? And the answer is 150 recovery residences per million. That is a long way from the 15 average that we're seeing now. Some people may even push back and say that that's not realistic or that's too many, but I think that we can look to Philadelphia for some answers. Philadelphia is one of the most well-respected, or has one of the most well-respected and well-developed ROSC. And when I say ROSC, I'm talking about a recovery-oriented system of care. This is the movement, this is the future of our industry. Luckily, Philadelphia understood the value and the need for recovery housing to the point where they initially created a recovery housing unit within their Office of Addiction Services. Since then, that unit has spun off to become PAR, which is the state affiliate of NAR. But back in 2007, they did the most comprehensive recovery residence survey that we have to date. And they found that there were 124 recovery residences per million. So we're getting close to that 150 benchmark, but still we're ways away from the average of 15 recovery residences per million that we currently have. So let's take a look at how we can get there. I think we need to think about, you know, how do we increase capacity, as well as how do we increase capacity or at least maintain, how do we increase quality or at least maintain quality. So we can help current providers increase capacity. We can reduce attrition rates and lower barriers. We can attract new providers, as well as define standards. And that's one of the things that NAR has done by defining the 4 levels of support. And we distinguish quality. One thing that NAR has done is created a certification program based on our standards. And we can educate, much like what we're doing on this webinar today. We can educate and advocate for best practices. So I realized that I covered a lot of information in a very short period of time, but I just wanted to frame the conversation for today. As a reminder, if you have any questions, please post them over into the right column so we can get to them a little later on. But without any further ado, I would like to introduce our next speaker. That's Bill White. From counselor to clinical director to senior research consultant, Bill has worked full-time in the addiction and recovery field since 1969. Bill is the co-author of a primer on recovery residences, which is available for download as a part of this webinar. Plus, he is the historian that wrote the award-winning book, Slaying the Dragon, The History of Addiction Treatment and Recovery in America. And he's the author of over 400 resources that can be found at williamwhitepapers.com. Bill, thank you for all of your contributions and for helping us raise awareness around the need for recovery residences today.
Thank you, Jason, and thank all of you for joining us today. I've been asked to offer some preliminary reflections on the role of safe living environments in the recovery process. And I'd like to maybe offer, 6 brief reflections on that question. I want to begin by talking about, what it takes to maintain recovery. And if you look across secular and spiritual and religious pathways of recovery, as diverse as they are, one of the things we find are 4 core rituals of recovery maintenance across those pathways. And those include, again, daily rituals of centering, which might be thought of in terms of meditation or prayer or self-reflection or personal goal setting at the beginning of a day or evaluation of the day at the end of the day, but it's how one comes into oneself and gets refocused on sort of the recovery goals and living a life in recovery. And then we have mirroring rituals, which are rituals through which we interact with others in recovery and other people who share recovery-based values. That may take place in the context of recovery mutual aid, or it may take place in a larger context of relationships in the community. And third, we have acts of self-care, which are acts that begin to repair the damage not only to ourselves, but the damage to our families and immediate social networks and those that are closest to us, and repair of the damage that's been done through the addiction process. And finally, we have this fourth category of unpaid acts of service, which really reflect our growing understanding of the helper principle, which is the idea that one of the activities that is most predictive of long-term recovery stability are these acts of service or acts of helping other people. Now, the way these four rituals tie to the issue of housing is the fact that the demands of homelessness and the threats of unsafe and unstable environments consume so much energy and bring so much crisis and drama into our lives that it makes it nearly impossible to perform these maintenance rituals. And in the absence of those rituals, we become very vulnerable to the resumption of alcohol and other drug problems. A second piece is that the living in the homeless environments and some of the chaoticness that involves that, and also living in unsafe, unstable, transient living environments, not only are we not able to perform those recovery support functions, but even worse, we're exposed to a wide variety of stimuli that really increase drug craving and drug-seeking activities. And those include exposure to people, places, and things associated with past alcohol and other drug use. It also frequently puts us closer to the culture of addiction that many of us were enmeshed in during our active years of addiction. And for many people, the transition from addiction to recovery is not only a profound intrapersonal journey, it really is a physical journey between two very different physical, social, and cultural worlds, a transition from a culture of addiction to a culture of recovery. And one of the dimensions within that culture of recovery are recovery-conducive living environments. And again, the criticalness of those environments, not only in terms of recovery initiation, but also in terms of long-term recovery maintenance. I also want to talk about, as a third point, the large number of people with histories of addiction who also bring histories of developmental trauma and trauma from unsafe environments. And what the continued presence in unsafe environment does is it continues to trigger this alarm reaction that in its extreme we refer to as PTSD. But that alarm reaction that begins to trigger issues of threats to safety goes through three fairly predictable stages. And that's an alarm reaction that initially signals that threat, and a stage of resistance when we try to mobilize resources to respond to that threat, and a stage of exhaustion after one or repeated experiences of this response. And I want to emphasize that when we've had a history of those responses and patterns of self-medication in response to all three of those stages, that unsafe living environments pose a major threat to recovery initiation and recovery stabilization and recovery maintenance. And it's only within the context of safe housing and safe living environments and social environments surrounding them that we begin to bring these alarm reactions and the risk of self-medication under control. There's a fourth area And that relates to how different problems begin to interact synergistically to sabotage the recovery process. The vast majority of people coming into addiction treatment in the United States today, as all of you well know, present with multiple concurrent or sequential problems. And if we look at the service systems in the United States compared to the slide that I've presented to you, what we see is a categorically segregated service system. And what that means is we have different silos of thinking and silos of service practice representing each of those problems. And we've sort of built that system on the assumption that people will cooperate and have one problem at a time. Only unfortunately that has clearly not been the case. And what we see is that the norm right now in addiction treatment programs throughout the United States is the emergence of multiple problem clients and families as the norm within those service settings. The danger gets to be that no matter which agency intervenes in their specific problems, the other so-called secondary problems come in and begin to sabotage those efforts at problem stabilization. And what it's beginning to call for is this movement towards integrated models. Now, put another way, put specifically into the context of addiction treatment, I would argue today that we are bringing significant numbers of people into addiction treatment whose problems are so severe, whose problems are so complex given this multiplicity of problems, and also chronic, meaning that these problems are not only present, but they've been present for a very long time and are entrenched. And that with those, that we continually recycle individuals through very brief models of intervention that have very little likelihood of generating successful long-term recovery outcomes. And when those recovery outcomes don't unfold following brief intervention, all too often we blame the client for that failure. And I've tried to argue in much of my writings that that's not a personal failure, that's really a systems failure, that the person was not in a set of resources that had any reasonable likelihood of generating successful outcomes. What that means is not only beginning to integrate services to address these problems simultaneously and over time, but also beginning to create a world where people can recover in. And we're seeing that with the emergence of recovery residences. We're seeing that with the emergence of recovery schools and recovery community centers, the dramatic growth of recovery mutual aid societies, recovery cafes, recovery sporting venues, and on, meaning that we are beginning now to finally build a flourishing culture of recovery in the United States beyond just the rooms of recovery mutual aid groups, an environment where people really can sustain their recovery until it's stable and self-sustainable. If we look at this problem synergy that I talked about, I just want to underscore again that that synergy inhibits the personal resolution of any single problem. It undermines the effectiveness of all of our service systems and inhibits the capacity to capitalize on recovery-enhancing opportunities. These are the individuals who can tell stories in which they've hit bottom, so-called numerous times, to the point that there's no more hitting bottom, they're actually living on the bottom. And that what provides opportunities for recovery to them is not more pain in their life, but opportunities for hope. And part of that hope is grounded in finding an environment in which recovery is flourishing. The next piece that I want to talk about is the relationship between problem severity and complexity that we've been highlighting and what we're beginning to learn about recovery capital. The work of Granfield and Cloud and others of us who've researched this have defined recovery capital at 3 levels: intrapersonal, family, and community. And we're talking about recovery capital as internal and external resources that can be mobilized to initiate and sustain long-term recovery. And what I'd like to illustrate with this matrix that I've presented to you in the slide is the following. You can read the matrix down or to the right, and I would suggest two interesting combinations here that are of particular importance. If we have high problem severity and low recovery capital on the right side reading down, this typifies many of the clients coming into publicly funded addiction treatment programs in the United States today. And in a critical piece of that combination is when we see that, we can bring problem severity down through acute stabilization. The problem is without elevating not only the internal recovery capital, but also the external recovery capital in the community, meaning that sober living environment, then there's significantly compromised probabilities of this person finding and sustaining long-term recovery. What this proposes to us is not only interventions with individuals to raise recovery capital, but environmental level interventions to begin to create safe, sober living sanctuaries within the community at all of those different levels that Jason described in terms of levels of recovery residences in the United States. So people have choices related to their needs for that kind of environment. There's another combination here that I'd like to reference because this is a combination that we tend not to think of when we think of recovery residences. Imagine somebody, for example, who brings low problem severity and complexity, but very high personal vulnerability. And as many of you know, we could define that personal vulnerability in a lot of very clearly predictable ways, such as family history of alcohol and other drug problems, early onset of alcohol and other drug use, euphoric responses to their first contact with alcohol or other drugs, co-occurring psychiatric illness, early developmental trauma, alcohol and drug-saturated social environments. So let's imagine somebody with those vulnerabilities, but at the moment has low problem severity and complexity, meaning they're right at the beginning of what may very well likely be a very prolonged addiction career. But at the point of intervention or assessment, if we use a traditional kind of, for example, ASAM levels of care placement paradigm, we would say this person is not in need of high intensity treatment, nor are they in need of prolonged treatment. However, if we look at the low recovery capital and their high personal vulnerability, this person may be actually in greater need of resources and more sustained resources than the person with high problem severity and complexity, but also who has very high recovery capital. In that case, if you look at the low problem severity and complexity and low recovery capital, I think in the future we're going to find a number of individuals in this category for whom recovery residences and living environment and the culture of recovery and involvement in that culture and those environments may provide a way to abort what could have been very prolonged addiction careers. And so I think those are at least a couple of ways in which we can look at the issue of recovery residence in sober living environments as critical to long-term recovery for people at present with both high and low problem severity. Finally, I want to talk about what we're learning that living in drug-free environments and living with other people in recovery actually does in terms of recovery initiation. We know in terms of the studies of recovery capital that general support can play some role in recovery initiation. And by general support, I'm talking about the general, well wishes and offers of support from family and friends and in helping institutions within the community. But an interesting and very important finding that we are discovering is that general support alone rarely dictates recovery outcomes. That what we need beyond general support is recovery-specific support. And that may come in the form of specialty treatment. It may come in the form of recovery mutual aid, but it definitely is going to come in the form of relationships within the environment that provide significant support for alcohol and drug problem resolution. And so part of what sober environments do, and the reason those environments are so critical, is the ability to saturate that environment with those recovery-specific supports. That, in turn, is based on some things that I've wrote about recently, in which I've suggested that recovery is contagious. And I mean that as socially contagious, meaning that many people initiate recovery more out of having got caught up in it as opposed to having initially chosen it. By the way, not unlike how they got caught up in addiction before it was a choice to continue drug taking. Again, just sort of a drifting process. That recovery contagion is generally spread through what I've described as recovery carriers. And these are individuals who really do make recovery contagious by the quality of how they live their lives, in some cases by their personal charisma, and by having things that people who are addicted observe and see and want to incorporate into themselves. That value of exposure to recovery carriers can come in multiple formats. It obviously can come in recovery mutual aid formats. It can come through the delivery of peer recovery support services. Clearly, recovery supportive housing and some of the outcomes of that, which we'll review later in this webinar, and also recovery supportive educational and work environments. And again, finally, what those environments provide is not only opportunities for one to be helped in one's recovery stability, but the ability to reach out and help others in that process so that the helping becomes reciprocal. I think you will find as we proceed that this issue of the environment can be as strong a predictor as recovery outcomes as any kind of intrapersonal characteristics, and in some cases more so. For example, we continue to recycle adolescents in and out of acute episodes of stabilization, who we then release and send back to their natural environments that generally devour them within days or weeks of their attempted reentry into the community, as opposed to our ability to work in those communities to build physical and social environments in which youthful recovery can thrive. So with that, I'm going to close and we'll move on with the webinar. I'll look forward to our discussions of these points later.
Bill, thank you very much. And if people have questions, please feel free to use the Q&A and we'll get to them at the end of the webinar. I'm now going to move forward and talk about telling your recovery story. And Jason is going to follow up about talking about recovery residences. And these combined presentations have to do with really how do we convey the contagiousness of recovery through our storytelling in language that people can understand and appreciate, and to get a broader sense of what it means and why it makes sense to invest in opportunities for people to live in recovery residences. So our goals in this part of the webinar are to learn briefly about messaging and Faces and Voices of Recovery's messaging, and then using recovery messaging in your advocacy and with the media. We have a much longer message training on our website if you're interested in taking a look at that after the webinar, and it's available on a DVD as well. And many of you may have already seen in pre-release this exciting new documentary called The Anonymous People, and snippets from our recovery message training are part of that documentary, and I really encourage you to take a look at it, and you can go to theanonymouspeople.com to find out more about that. So let's talk a little bit about what is a message. It's really the most important thing, what you want people to hear, and it's critical that we think about and understand what it is that we want to be communicating. And you may have heard on TV or reporters and politicians talking about staying on message. And the reason that They use that strategy, and producers of products use that strategy and come up with catchy jingles and slogans is they want you to remember a particular thing. And then similarly, when we talk about recovery, we want to help people understand what it means to recover, and so that as we move forward talking about the importance of recovery residences, we can also talk about recovery in a way that the public, policymakers, and others understand what it is that we're talking about. So about 5 or 6 years ago, Faces and Voices undertook a survey of people recovery and also the general public to develop this recovery messaging. And not surprisingly, one of the findings in our survey was that a majority of Americans have been affected by addiction. But one of the major purposes of the survey, a work that we did, was to come up with language that the recovery community, meaning people in recovery and family members as well, could talk about recovery, that the public would understand what we were talking about, and at the same time, people in recovery and family members would be comfortable delivering this message. So we tested a number of words and phrases. In the cancer movement, people talk about them as survivors, themselves as survivors, for example. In our focus group, the recovery community wasn't comfortable using that language, being an addiction survivor. And so we developed this new messaging, which is a way for people to talk about recovery in such a way excuse me, that people could understand what it means to recover. So we did focus groups all across the country to figure out how to do this, and then we tested these messages, again, with people in recovery and with the recovery community. So the whole purpose of doing all this research was that we knew that if someone had 26 years of recovery, for example, and they identified themselves as an addict, people in the general public thought the person was going to turn around, go home, and start using. So we needed to have language that we could use in the public sphere that was perhaps different than the language that people were used to using in the context of their mutual support meetings. So that was really the impetus for doing this research, was to come up with language that the general public could understand what it was that people were talking about when they were talking about their recovery, and then perhaps even more importantly, what it means to find recovery. And for people who are living in recovery residences, this is really, really important so that we can convey what it means to be in recovery, as well as being a person who is supporting opportunities for people to have the recovery residence that works for them. So we spent a number of years doing and a number of months developing this research. And so the goals in terms of developing this was to expand opportunities for recovery and break down discriminatory barriers by putting a face and voice on recovery, talking about recovery in such a way that people would know what it means to get well, to end discrimination, and as we're going to hear later on, NIMBYism in terms of citing recovery residences is a really important issue. Broadening social understanding to achieve a just response to addiction as a public health crisis, not a criminal justice issue, and to build our national recovery advocacy movement. So that was the goals of this messaging that we put together. And as I mentioned earlier, this is a really brief rundown of this messaging, and I want to share with you what the basic messaging is. And we ask people to use their full name. So my name is your full name, and that's the first part of it. The second part of it is saying, I'm in long-term recovery, which means, and then we ask people to say, I have not used alcohol or other drugs for however many years. They have been alcohol and drug-free. And that's because we found out, excuse me, when people heard the word recovery in this research that we were doing, they thought it meant that someone was trying to stop using alcohol or other drugs, which is not how the word recovery is understood within the recovery community. So right off the bat, we needed to define what recovery means to people, and then we introduced this terminology, long-term recovery, because people think that if someone says they're in recovery, they're still going to, they're really on the verge of start using again. So we really wanted to convey long-term recovery and also define that in terms of the number of years that someone is no longer using alcohol or the drugs. And you'll notice we don't say, I'm no longer drinking alcohol, I'm no longer shooting heroin, because one of the things that we found is when we name specific drugs of choice, that piqued people's interest in terms of that particular drug. So we really wanted to be much more generic in terms of what it means to be in long-term recovery. Then the third part of the message is why you're talking about your recovery story, which is really important. We're not asking people to brag about the fact that they got into recovery, but really it's the idea of telling your story and talking about recovery in a way that the public understands what you're talking about and what your life experience is, to explain what the benefits of recovery have been to you, to your family, and to your life. So long-term recovery has given me and my family new hope and stability, and my life and the lives of millions of others like me are better as a result. So it's developing kind of guidelines for how to talk about recovery, and each person who does this training and thinks about how to talk about their recovery and deliver a recovery message tailors it to their own particular situation. So it's really personalizing your recovery story and telling it in a way that others can understand. So as we think about recovery housing and recovery residences, it's knowing in advance what you want to be talking about, focusing on your key points, what it is that you want to be getting across, and then applying your message so that everything that you say restates or reinforces your message. It's so easy to go on and on about a particular thing and say, I have another idea, there's something else I want to say. But when it comes to messaging and getting across the reality of recovery in different situations, it's really, really important that we make sure to keep in mind what it is that we want to be talking about and talking about in a way that makes sense and delivers our message about the reality of recovery and the importance of recovery residences. So when you think about delivering a message, we have what we call having a message framework, and it's kind of how do we think about what it is that we want to be saying. And so when we talk about recovery residences and our personal recovery or a family member or a loved one's recovery, it's thinking about it in terms of stating the goals, putting a face on recovery, highlighting the problem, describing the solutions, or ask what it is that we want to have happen, and then perhaps most importantly in terms of offering hope and conveying the reality of recovery is explaining how these changes will benefit the public. How can we change public attitudes about people in recovery, the need to build recovery-friendly and recovery-oriented communities in such a way that people will say, hey, this really makes sense to move forward and to invest in people and invest in long-term recovery in our communities. So what we're trying to do, and we're excited to be working with you all and others, is to be speaking with one voice about the reality of recovery, to demonstrate by our presence, by our stories, by our experiences that people can and do recover. So that's speaking with one voice in the sense of talking about being in long-term recovery, explaining to the public, family members and friends what that means, why it's important, and why it should be supported. And probably one of the most important parts of our recovery stories and sharing our message is that we make it personal, because not only does that add credibility, but it also builds relationships. It makes it real. Real people recover, and we need to acquaint others, including policymakers and the media, about what a face and a voice of recovery looks like, make sure that people understand what long-term recovery means, and then talking about our recovery experience, not our addiction experiences, which is our recovery story. We are talking about the solution, not the problem, and part of the solution is for people to have a safe place to live that supports them in their long-term recovery. So that is a really important part of our message. So the problem that we have, and this is the core part of the message, is that we need more opportunities for people to achieve long-term recovery. The public and policymakers are beginning, but they yet don't fully understand the importance of a safe, sober, and peer supportive place for them to live. And public perceptions and attitudes about recovery lead to misunderstanding, and we need to create an environment that is recovery supportive, and part of that is sharing a recovery story with a united voice explaining what recovery means. So part of the solution is part of what we're all about here today, which is building this national movement, putting a face and a voice on recovery to break down misperceptions that will change attitudes, which is stigma, and also to change policies, which is discrimination. So at Faces and Voices of Recovery, we talk about ending discrimination. And in the process of doing that, we are educating the public through recovery storytelling about what recovery means and changing attitudes or stigma. And so building a growing, organized constituency of people in recovery, family members, friends, and allies who are sharing this recovery message and the recovery experience. And one way that I know many of you are involved in doing and want to encourage you to continue to be involved in is taking part in activities like Recovery Month, which is held each September. Last year, over 100,000 people all across the country participated in Rally for Recovery. It's a real opportunity to put a face and a voice on recovery and use recovery messaging in your community. Having open houses at recovery residences and invite people in and hear about people's recovery stories and make that relationship building happen through that sharing of what it means to be in long-term recovery is one really important way to do that. There's resources on Recovery Month at recoverymonth.gov. This year's National Hub event is going to be in Providence, Rhode Island on September 21st. So I really encourage you to use opportunities like these to show and demonstrate what recovery looks like in recovery residences and to use this recovery messaging to help make that happen. So please go to our website at facesandvoicesofrecovery.org if you'd like to download the DVD, look at the recovery messaging training that we have, and bring that to folks in your community.
Thanks, Pat. And for us to kind of build on the advocacy best practices that Pat talked about, let's look at how we should talk about recovery residences. You know, if you walk away with anything today, after today's webinar, it's that language matters. I mean, how we talk about recovery and how we talk about recovery residences can make a huge difference when we go out and advocate. And we need to be focusing on strength-based words and phrases because that's what works. So an example could be people are building new lives in recovery, supporting one another as they live with others who are sharing their experiences. Second example would be a recovery residence is a type of housing where people learn to live without using alcohol or other drugs. Standards have been developed for these residences, and there are 4 different levels based on how much support people living in them receive. So some of the strength-based words that I see in these sentences is the word recovery, recovery residence. We talk about peers supporting each other. We talk about people learning to live without the use of alcohol and drugs, and we talk about standards. You know, some other strength-based language other than calling something, you know, a recovery residence, we could refer to it as recovery housing. I think that's a very positive word. Other terms, we could call them recovery-oriented housing, recovery supportive housing, recovery conducive housing. So these are all examples of strength-based words. Now, there's strength-based words, and then there are problematic words, things that we that don't work or that we may want to mindfully stay away from. For me, probably the biggest on the list is the word transient housing or a transient. It sounds very temporary. It sounds very unstabilizing. Unstable for the individual themselves, possibly unstable for the people, the peers living in the house, but it sounds really unstabilizing for the neighborhood, and that's why you see neighborhood associations and policymakers kind of raising an eyebrow when they hear the word transient. Another word that's kind of similar is temporary or temporary housing. It doesn't suggest that the resident will be contributing to the community, that being the community within the recovery residence or the community, the greater community, the neighborhood. Again, it can be viewed as destabilizing, especially when you compare temporary housing to permanent housing options. Transitional, we talked a little bit about this word earlier. It's like temporary. It places the focus on moving in and out rather than having the individual focusing on the recovery and about deepening the relationships within that community.
Yes, sir. I'm actually on a conference call while I'm talking from the office home. So let me call you when I get off the conference call.
Yeah, could whoever's asking them to get off the conference call, could you please mute your phone? Thank you.
Yes, sir.
So, you know, it's about recovery residences are about people staying in a recovery home, not only for their own recovery, but to help and support their peers. You know, the other word is halfway house, and I know there are a lot of great programs out there that are doing amazing work that refer to themselves as halfway house. And I don't want to take anything away from you. I actually want to thank you for the good work you do. But when we're choosing our words and we're thinking about ideal words, halfway house has some problems. It implies transitional. I've gotten in so many lively debates with people around what's the difference between a quarter house and three-quarter house and halfway house. And the truth is that's really inconsistently used, and we need to use kind of standardized language so when we say a word, we know what we're talking about. And probably even more confusing is that criminal justice has taken the word halfway house to describe these large institutional-like settings where parolees finish their time. And, you know, maybe some halfway houses do meet recovery resident standards, but then there are others that don't. So now that we're developing this skill set called advocacy, and we're finding out the right words that we're supposed to be using to go out and advocate. So what should we be advocating for? And so I want to present three different concepts, four different concepts maybe we can use as case studies to build on our skills. So the first is recovery residences are more than just housing. At a minimum, they provide recovery support through a family of peers. And the reason I wrote that is some of the issues that I've been seeing are kind of around funding. You know, funding can be earmarked for brick and mortar for building the building. Some funding is earmarked for rental assistance or housing assistance. And then some funding is earmarked for other support services. And so where does recovery residences, fit in that? I can remember one particular conversation. I've been participating in the local ROSC meetings, the Recovery Oriented System of Care meetings, and I would go and sit at the peer recovery support services table where the peer coaches, recovery coaches were, and I would talk about recovery residences, and they would say, no, your indirect support, your housing, you should go sit at the housing table. And so then if I move over to the housing table and talk about recovery residences, they would say, no, your peer support, you're not housing in the way that we think about housing, so you don't fit over here either. And so I think we really need to advocate for ourselves and make sure that we're not falling between the cracks, and also make sure that we're advocating for recovery support services. It's the non-clinical recovery support element within recovery residences that's the social model. And sometimes clinicians maybe not value it as much, and people outside the recovery world need to hear that it's that element that's actually kind of the magic that happens in some of these homes. So some messaging that we may want to use to advocate around this concept would be, for people in early recovery, housing is critical. Many also need other supports to stabilize and sustain their recovery. Recovery residents offer those additional supports, starting with peer-to-peer support within a safe, sober living environment. Many recovery residences also offer a variety of other services, creating a continuum of support that cost-effectively matches the resident's need. So the next concept I would like to highlight is, getting a life back in the community, reintegrating into community, especially coming out of the criminal justice system, the reentry population. They face so many barriers. There's the affordability barrier. Oftentimes, there's background checks, and they have a felony record, or even bad credit. That can be a barrier to, for them to get housing and the services that they need to really, prevent them from relapsing or returning back to the prison system. There is a lot of lip service that's given that, housing and recovery residences can help someone as they reintegrate back in the community, and that it actually helps them from going back to jail, and there's a huge cost savings around that. But unfortunately, I don't see the investment in housing and the investment in recovery residences when I start talking in these conversations. We need to put money where the mouth is. So what is some messaging that we can use around this? Here's a sample. When people have stopped using alcohol or other drugs, it doesn't make sense for them to return to living situations and communities where using alcohol or drugs are the norm. Plus, oftentimes families and friends don't know how to support someone in recovery. This places individuals at high risk for starting to use again or for committing crimes. Recovery residences offer people in recovery a sober, safe, and affordable means of integrating into a community, building a new family of peers who can support each other in recovery. It's a home where they can thrive and contribute. So let's go to the next concept that we can advocate around, and it's really around the continuum of care. So if substance use, if addiction is really a chronic disease, then we need to treat it like any other chronic disease and provide that continuum of support. We need to be focusing about how can we get someone to that first year, or how can we get to someone to their 5th year of recovery, just like we would with any other chronic illness. And so if that's true, we need to invest more in the continuum of care. And, recovery housing needs to be a part of that, because everyone can agree, or a lot of people agree, that, recovery housing can boost outcomes. Once again, I recently was talking with a treatment provider who was interested in getting a grant for a particular population, and they knew that housing was going to help this population. But when we got down to the table and started kind of, carving out, what funds would be allocated where, there was this instinct for them to over-allocate or over-invest in the acute care services and under-invest in the continuum of care. So with the ROSC movement, I think that we can engage in some of these conversations and help advocate for a stronger continuum of care, which includes an investment in recovery residences. So some messaging around that could be, recovery is a journey, and it's been demonstrated that the longer someone stays in a supportive environment, the more likely he or she will be able to stay alcohol and drug-free and live a fulfilling and productive life. Recovery residences offer a sober, safe, and healthy living environment at every stage of recovery. They cost-effectively provide levels of support to match each person's need. That way, a person can better afford the help they need to recover for the long haul. And the fourth is around recovery housing. Recovery housing is housing of choice, not the last resort. Oftentimes I'm in conversations and people don't understand the value of recovery residences or living together as a group. In their mind, a recovery residence is just one step up from homelessness. And so your options are be homeless or move into group housing. And that's just not true. I mean, we know so many people that they have nice houses, they could afford their own apartment, but that's not where they should be living. They end up choosing living in a recovery residence because that's where they get the peer support that they need to start and sustain long-term recovery. So some messaging that we could offer here is research has demonstrated that people living in a recovery residence get and stay well because of the use of this important community resource. Even when they have other options, many people choose to live in a recovery residence because of the opportunity to take charge of their lives, experience healthy social support, develop new relationships, and access the services they need to sustain recovery. So those were 4 examples. I'm sure y'all could come up with several other examples of things that you want to advocate for, and hopefully we've given you a template of, identifying the issue, developing some strength-based messaging, and then going forth and advocating. And when you're advocating, remember that recovery residences work, and we need to share that. We need to share it with our stories. And whether you're a person that's living in a recovery residence now, maybe you're a house manager or an alumni recovery residence, or maybe it was one of your loved ones that was living in a recovery residence, talk about what that experience looked like, those anecdotal stories. Did living in a recovery residence help that individual stay sober? Did it improve your mental health? Were you able to get a job or hold down a job or maybe even get a raise? And then there's the big three. Did a recovery residence help the individual stay out of jail, ER, or detox? These are very expensive to society. And so if we can show that living in a recovery residence is going to help someone stay out of jail, the ER, detox, a policymaker is really going to take note of that. Plus, did living in a recovery residence help someone find new purpose and giving back and value volunteering? And did it help them gain the peer support that they need? And did they start repairing those family and friend relationships that while they were in their disease, they may have taken out? So plus, there's this growing body of evidence. So where it's appropriate and when you can, use statistics. And Dr. Jason's going to talk more about research here a little bit later on. And there's also some great data in the primer on recovery residences, which you can download in the bottom right hand of your screen. So again, here's my contact information if you want to reach out and contact me directly. And if you have any questions on this section, please put them over in the Q&A section to the right.
Thank you, Jason. The next part of our session is going to be talking about our audience. Who is it that we are talking to? Who is it that we want to reach with our message about both recovery and the importance of recovery residences in terms of people getting well and having a safe place to live, and developing a family of peers, as Jason has talked about it, which is a really wonderful way to think about what goes on in recovery housing and in recovery residences. So when we talked earlier about our recovery message, there are lots of different places and different contexts in which we are going to be delivering this message. And one that's really, really important is in terms of talking with family members. So, it may be in the context of an ongoing relationship with a family member or reuniting with a family member and figuring out how to talk about what it means not to use alcohol or other drugs. That's an intimate conversation. It's not necessarily an advocacy conversation, but finding language to talk about what it means to be in recovery and to have a safe place to live and to support your recovery. That's an important conversation as we think about particular audiences. And in many cases, those relationships that we have with family members can convert them into the messengers about why recovery residences are important for people in seeking and sustaining their recovery for the long haul. Sometimes it's easier for a policymaker to listen to a mom or a dad or a spouse or a child talk about why it's important that their loved one has a safe place to live as they seek and sustain their recovery for the long haul. Policymakers may be more interested in hearing from that person in your life rather than from you yourself. And as we develop campaigns and advocate on behalf of recovery residences, we need to think about who the messenger is, and sometimes family members and others may be the best messenger. So helping them to understand how to talk about recovery residences, as Jason has just done, and how they can talk about what your recovery or a person in recovery's movement on the recovery journey means to the family, makes them be a really important messenger as well as an audience to talk with about recovery. Another audience is friends, and this could be new friends, and it could also be friends from a period when a person was in active addiction. Is how to talk about what recovery means, and using this language that we've developed to have a way to begin conversations. On our DVD, Our Stories Have Power, one of the young women who attended, I had a conversation with her recently. She actually took a refresher course of our recovery messaging, and she said she has found this recovery messaging the most useful in terms of talking with her friends about what her life experience has been. She said, you know, I didn't want to talk about what my life was in active addiction. I want to talk about who I am today. So this recovery messaging is very useful in terms of reaching out both to friends and to neighbors to explain what it means to be in recovery, to explain your recovery journey without having to go in and talk about your addiction story. So using this messaging and talking about recovery residences as part of the recovery experience is a way to educate people and to broaden understanding about not only what the reality personally of recovery is, but also the value to community, the value to the nation, and also obviously a cost savings, as Jason was talking about earlier. But this recovery messaging is a way to feel comfortable expressing what recovery means and an individual experience with recovery. Similarly, this recovery messaging in other audience is coworkers. Not everyone may want to share their recovery story with coworkers, but again, it's a way to do it, not only without violating the traditions of a 12-step program, but also to think about how to stage discussing what it means to be in recovery and the recovery experience in a way that helps to explain the recovery journey and to help people understand why it's important to invest in opportunities for folks to get well. Another really important audience is the media. There are many opportunities to talk about, growing numbers of opportunities to talk about the recovery experience with the media, and for folks who are, such as yourselves, who are really engaged in terms of supporting recovery residences, having a way to talk about recovery both positively and proactively in terms of, wanting to showcase and highlight why recovery residences are important, but also when situations arise when there's negative media about recovery residences, having a way to talk about and deliver the message of why recovery residences are important and that the people who are living in recovery residences are in recovery is really, really critical. So thinking about developing specific messages relating to specific situations is really important, but always hearkening back to what the message is in a particular situation and developing messaging and talking points to address those particular situations. And then the last audience is public officials. And, you know, when you think about how we talk with our public officials, there are like those ways that we see about on TV or read about in the newspaper where there's a city council hearing or a congressional hearing or something like that. That's one place that we can reach that audience, but there are a lot of other opportunities that we can develop and create to communicate with our public officials. And that's why activities like Recovery Month are so important. That's why inviting city council members, members of Congress, and others to visit recovery residences are so important because that's when you can build connections with them and use this recovery messaging to target public officials so that they understand why recovery housing is so important, and they meet people who live in recovery housing and see how important it is and how people are thriving. So as we're thinking about these audiences and how we communicate with them, we have to also bear in mind who it is that we're really trying to reach. And I know I am very used to when I'm talking to somebody, that's the person that I'm talking to and I'm communicating with them. But when it comes to media interviews, the person that you're speaking with, i.e. the reporter, is kind of the intermediary. Who you're really talking with are the people who are reading the newspaper, reading the blog post, who are watching TV or listening on the radio. So it's kind of a different concept, meaning your audience may not be the person that you're speaking with, but rather the people that that individual can reach. So thinking in that context, similarly, in a debate situation, if your city council is debating a zoning ordinance or that is going on. Your audience may not be the person, isn't really the person you're debating with, but rather the decision makers who are listening to the debate and who it is that you want to be influencing. So it's kind of another level that we really have to keep in mind as we're developing our messaging and delivering it in different kinds of places. So when we think about the language that we use to those different audiences, it's different, and we have to be very clear about, in our own minds, about who it is that we're talking with, making sure that we don't use jargon, and as Jason went through the different words that are used to talk about recovery residences, and we live in a jargon-laden world. So really making sure that we speak in simple terms, that we know that people are understanding what it is that we're talking about, and that we also use language that in a media environment reporters will pick up on, people who are listening to us speak about this important issue, perk up their ears. Something that we use sometimes and suggest is living in a recovery residence, help me pick up the shattered pieces of my life. So helping people just kind of engage around what is a really powerful opportunity for people. And then using anecdotes from your work, your life, and your community to support your points. And most importantly, making it personal, because really that is what it's all about. So really making sure that as we go ahead and communicate, that we are using words that people understand, using language that engages people, and understand and know who it is that we're talking to. So do we want to build a relationship with a friend, or rebuild a relationship with a friend to talk about a recovery? Are we talking in a media environment, or are we trying to engage public officials in our advocacy to get more resources in our communities for recovery residences?
Thanks, Pat, for helping us understand how to customize our message. I'd like to introduce our next speaker. He is a leading researcher and an expert in recovery residences. Dr. Leonard Jason is professor of psychology at DePaul University in Chicago, Illinois, where he also directs the Center for Community Research. Dr. Jason's research led to Oxford House being listed on SAMHSA's National Registry of Evidence-Based Programs and Practices. And he has edited or written over 23 books, 541 published articles, and 77 book chapters. This includes co-authoring a primer on recovery residences and the role of recovery residences in promoting long-term addiction recovery, both which are available for download with this webinar. Aloha, Lenny. Dr. Jason is coming to us from Hawaii. Special thanks for taking time away from the beautiful scenery out there to be on the call with us. And thank you for all the work that you do and for helping us advance the field of recovery residences. Dr. Jason may be having difficulty getting on from Hawaii. Let's give him a couple of seconds. Lenny, is that you? Hello, Lenny?
Oh, yes.
Hey, Lenny. Yes, you're on just in time. Yes, I was just telling them aloha because you're coming to us from Hawaii.
Absolutely, and welcome. I'm at the American Psychological Association, and do you want me to begin right now?
Yes, sir. That would be awesome.
Okay. So my presentation is the role of recovery residences in promoting long-term addiction recovery. And as you know, I'm Leonard Jason from DePaul University. You can click the slide. So a group of people recently had a policy statement. It's like a white paper that was ratified by the Society for Community Research and Action, SCRA, which is a division of the American Psychological Association. And we had the executive advocacy and research committees of the National Association of Recovery Residences certainly take a look at our policy statement and approve it before we went on to the Society for Community Research and Action, where they endorsed it. And this policy statement talks about the value of recovery residences in the United States. The members of this particular white paper that was written were myself and some of the other people are on the next slide. And that's Amy, Doug, and Bill White, who you've already heard from earlier. So these people had a committee. We worked on this proposal for just about a year, and a lot of it came out of material from the primer that some of you are familiar about. So I just wanted to briefly talk about our research committee's effort to get a policy statement out. But first I wanted to kind of mention, as I've been at this psychological convention in Hawaii, I've noticed that there's lots of researchers who are kind of had networks where there's actually many, many institutions of higher learning and scientists working on things for the etiology and genetics and the biology of the brain. And we also see a whole bunch of researchers in addiction studies who are doing work on things involving prevention and treatment. So, and it's actually groups that are working within both of those domains in translational research. So it's very exciting, lots of developments. But these are large networks of scientists who are working to make these discoveries. And the one piece that I think is missing from this large entity is, what do we do after we prevent some problem? What do we do after we treat someone? What happens when they come out of a treatment setting? What happens in the environment that actually supports, endorses the types of changes that might have occurred? And I think that's the missing link. So let me tell you real briefly about my own involvement. Take the next slide. In recovery home research. I worked for about 35 years just on substance abuse issues. I first worked on issues of youth access to tobacco, trying to get merchants not to sell minors tobacco. And again, thinking about the environment and how that affects youth. And we need to not just think about the individual, but the social environment. And then I heard about this organization called Oxford House in the early 1990s. And for the last 20 years, I've been doing some research trying to understand kind of does it work and how it works. And just real quickly, one of the experiments that was funded by NIAAA involved individuals completing substance use treatment, and they were randomly assigned to either an Oxford House or usual aftercare, and 150 people participated in this study, of which 154 were approached. And all the participants were assigned randomly to an Oxford House or to a usual aftercare. And those assigned to the Oxford House were willing to stay there. And Oxford Houses, as most of you probably know, are democratic, self-governing communities, and that's been talked about throughout this webinar. Next slide. So one of the things we were interested in is what happens 24 months after treatment. And these are some of the effects. The traditional care, which is individuals get treatment and sent back into the community, only 35% were abstinent 2 years later. But if they had gone into an Oxford House for about a year, they actually had about twice the level of abstinence rate, 69% 2 years later, which is, again, pretty stunning. Next slide. In terms of incarceration rates, what happened 2 years later? Well, those who were in the Oxford House, only 3% had incarceration, whereas the rates were considerably higher in the traditional care. Next slide. In terms of monthly income, those in the Oxford House were earning about $989 per month, which is, again, beginning to get out of poverty, about $1,000 a month, $12,000 a year. Whereas if you're making about $500 a month 2 years later in traditional care, that's really tough to live on. I think that the income data were also very supportive of a structured environment to come into to help maintain types of gains from substance use treatment. This study, next slide, was widely disseminated in many different articles, not just in professional journals where we published it, in American Journal of Public Health, but also through newspapers. So again, giving some credibility to the fact that there are recovery homes like Oxford Houses that can make a difference in the trajectory of providing people a safe environment once they finish treatment to help them sustain that recovery. And as we all know, that we need something like 3 to 5 years of abstinence for having that more long-term effects. So our group, because of different research, this being one and many other people from our research committee, decided to put a policy statement together. This policy statement describes the emergence and rapid growth of recovery residences as a new addiction recovery support institution. It highlights research to date, for example, like the one that I just mentioned, on the positive effects of participation in recovery residences on long-term addiction recovery and related outcomes. And it champions a research agenda that would address many unanswered questions related to such participation. Next slide. It advocates for social policies, for example, laws, regulations, and funding guidelines, in which recovery residences can flourish. It also supports programs of education and training to increase referrals to these new resources by health and human service professionals. And it promotes programs to educate local political leaders and the public about the value of recovery residences for individuals, families, communities in the United States. Next slide. So we also made a series of recommendations. For example, national, state, and local agencies should support local networks of recovery residences. We also recommended enhanced funding for critical research related to recovery residences. We also recommended strategies to educate and train addiction treatment professionals and allied health and human services professionals on the value of recovery homes. Another recommendation was for public education strategies that will address the stigma and misconceptions often attached to recovery homes and their residents. In conclusion, we feel these actions will play a significant role in elevating long-term addiction recovery outcomes in the United States and contribute to the quality of life of individuals, families, and communities throughout the country. And for those of you who have interest in learning more about this policy statement, it's located at the Society Community Research and Action website, so that you can click on that and you can read the whole statement, which is available. I might say that since we have published this statement, we've actually had some very good press on it. It's only been out for about a month or so. We've had a number of reporters who have contacted me and other members of the committee and asked us about our opinions about recovery residences in different communities. The Oxford University Press has also recently put a blog out, and that will be out, I think, August 3rd, that just summarizes some of these principles. And that particular Oxford University blog gets something like 25 to 35,000 hits every month, so it's one of the more well-established ones. So we've had several newsletters and several kind of different organizations publish parts of our recommendations, and people even within the federal government have been interested, and we've sent copies to those individuals. They can begin dialoguing about the critical importance, about the environment, the social networks, the people that we hang around with, the people that support us in our recovery, and that's the critical, often missing link that we believe is so important for this addiction to be reduced and hopefully changed over time. So we're very excited about the initial reaction that we've had so far, and we just want to continue, letting folks know, and any people who are listening to this webinar, feel free to get in touch with us, and we'd be happy to provide information and other types of ideas as we're kind of trying to work on this. So I know that there was an effort to have a couple minutes at the end of my brief presentation for questions. I just wanted to throw it back to the moderator here. If there are any questions that have come in, I want to give a couple minutes for that. So, and if not, then that's okay too. I'll get back to my convention in Hawaii.
Thank you so much. I don't see any particular questions, so if it's okay, we would love to communicate with you, and we'll get back to everybody further if questions do come up later on. We really appreciate your taking time from your vacation to join us. From your work vacation, excuse me.
And it's a vacation, and also, but getting a chance to sit in on some really fascinating sessions. I've been to quite a few addiction meetings where, again, they're talking about the genetics. They're talking about the biology of the brain and the self-regulatory functions of the brain. And again, as I've been listening to these presentations, there's so many, great scientists of networks of people that have lots of money to kind of interact with each other and support each other's research. And we would love to see the same thing happen with the field that we're in, which is recovery residences, because we feel they're often the missing link. We can't treat people in isolation and expect to get long-term positive effects. We have to understand that the social environment is critical. And for example, we have found that to the extent that you have people who are in recovery in your social network, and people who are working, and people who are not involved in illegal activity, those are really the best predictors we find. So how do we find those social environments where people can enter those types of settings when often they don't have the types of environments to go to? How do we create these settings to really give these people a chance? So good. Thank you again, and appreciate the opportunity to address your group. Bye now.
Well, and thank you for bringing this message to the other researchers who are out there. I think, recruiting and engaging researchers who are looking at this issue from one perspective about how important ongoing recovery support and recovery residences is really critical, and really appreciate all your work to make that happen.
Great. Thank you.
Good. Thank you.
Bye-bye.
I'd like to introduce our next speaker, who is Tom Hill, who is the Director of Programs here at Faces and Voices of Recovery. Tom?
Good afternoon, everybody. This is Tom Hill. I'm going to be closing things out before the question and answer period, and sort of maybe generalizing some of the topics that have been discussed today. The whole idea of why now, why are we having this webinar, why are we having these discussions? We're in a really exciting time where what we call is that all the stars are in alignment. It's sort of a perfect storm. We have recovery-oriented systems of care. We've got those initiatives happening all over the country. I'll talk a little bit about that. We have the combination of the Affordable Care Act along with the Mental Health Parity and Addiction Equity Act, meaning that mental health and substance use disorder conditions can be treated on par with all medical conditions concerning insurance. And I just lost my screen. Here we go. And then the Affordable Care Act, which offers lots of new venues and new funding streams that might be available for recovery residences. We have managed care expansion. We have an incredibly robust recovery advocacy movement all across the country where people in recovery communities are doing advocacy and developing peer recovery support services, which have come to a new age of being highlighted and mature. And then we have, since so many of our community people have a criminal justice background, we have a lot of reform movement happening in criminal justice and drug policy. So there's a lot of things happening at once to make this a very, very exciting time. When we talk about recovery-oriented systems of care, Jason mentioned that at the very beginning of this webinar. It's really this huge shift from a crisis-oriented, professionally directed, acute care approach of addiction and recovery to this much more expanded person-directed recovery management approach that addresses what long-term recovery looks like and what people need to stabilize and maintain long-term recovery over a long period of time. So it's looking at things in an entire new way. Part of what we like to think about is how do we mobilize all of the resources in our communities to give people the dignity and respect they deserve, to engage people to seek help in the health system, because so many of us in active addiction have not had access to the health system, and they're new and sometimes very intimidating systems to navigate. Help more people find and sustain long-term recovery. Lift the discriminatory policies and barriers that exist, because if there's more services and more supports, they don't count for much if we can't access them because of discriminatory barriers. And then how do we build the capacity of communities and organizations and institutions all across the country to support this idea of long-term recovery? One of the things that we like to think of it as a strength-based and resiliency approach. So we want to build on those strengths that individuals, families, and communities inherently have and help people take responsibility for their own long-term recovery. We want to be able to make services and resources available that people can use to meet their needs, and we want to sort of expand that menu of services and supports so that it addresses our people's recovery across that continuum, and to offer supports that work for each person to restore their lives on an ongoing basis. So when we think about what people need to initiate and sustain their recovery, the whole thing about this webinar is really the whole idea of to have stable recovery, you need a stable place to live, first and foremost. If you don't have that, it's really hard to keep any kind of stability in your recovery. The second thing that's really important is people need some kind of job, some kind of employment, some kind of career, some kind of meaningful work, and they often need means to get there. So they need readiness, they need resume building, they need interviewing skills, they need all those things that people often lack from being in active addiction. Education and vocational skills, getting a GED, going to community college, getting your bachelor's degree, those kinds of things, if those are goals. Developing life and recovery skills, a whole new idea of health and wellness, nutrition, fitness, all of those things that people are now paying attention to with their bodies and minds in recovery. And then this whole idea about community connection, families of origin and families of choice, the sense of belonging and purpose, and this belonging to something greater than ourselves. Connection to community is so important. And for people that are practicing early recovery, the whole idea of how to have fun in recovery and how to be in a community with people that know how to have fun without using substances is a huge, huge thing. So in addition to all that, people need help with legal issues, criminal records that need expunging, financial assistance with back debts and back taxes, learning how to do some basic budgeting, overturning revoked licenses that happen as a result of being arrested, professional business driver's license, regaining custody of children, and negotiating and navigating the child welfare system, developing skills in relationships and parenting, having those social support networks that honor sobriety. So that often means not only getting rid of old social support networks with people that may still be using, but developing new social support networks with people in recovery. And then that whole idea of connecting with community. So this leads us to talk a little bit about peer recovery support services, and you can think of certain types of recovery residences as a recovery support service or even a peer recovery support services. But there are services that are designed to help people initiate, stabilize, and sustain recovery. They're non-professional and non-clinical, so they're not treatment-oriented, they're recovery-oriented. They're also distinct from 12-step groups and other mutual aid supports. So they're not AA, they're not NA, they're not any of those 12-step or mutual aid supports. But they also do provide links to professional treatment and provide links to supports in the community that might be 12 steps. And I think the most important thing is they're provided by peers, people who have lived experience with both addiction and recovery and have that commonality and sense of recovery purpose and can help imbue that with other people. Why do they work? Well, the main thing is they focus on establishing trust and building relationship with the other person. That peer-to-peer component is really important, that I've been there, I've done that, I can help you too. Also that people who do the help also get the help, so by putting your hand out and helping somebody else, it supports your recovery as well. It supports a person's strengths to build recovery capital. Bill White talked about recovery capital and the whole need of external and internal supports that people need to identify where they exist in their life and where they need to be reinforced. They promote people's own choices and goals, and we do that through self-directed recovery plans. They utilize the recovery community strengths and gifts that are inherent in the community and help to locate where those are at. And they provide entry to the healthcare system and services, something really, really important in health reform that many of us, as I said earlier, haven't had access to the healthcare system. So we may need some extra attention in that area. And then finally, we like to think of it's not just that recovery works, but the recovery is an expectation. So this leads us back to advocacy, that we've talked about that throughout the webinar also. So with all of these, with recovery-oriented systems of care, with peer services, we need to stand up and advocate that these become institutionalized within our systems and within our communities. We also need to advocate that barriers to recovery get addressed and lifted. So we do recovery community representation at policy and systems levels. We lift discriminatory barriers to recovery and promote civic engagement so that people get back into society as productive members. With health reform, we're working to state by state to include peer recovery support services as part of the essential health benefit package so that they'll get reimbursed through insurance. Through the Health and Human Services comprehension, I'm going to skip that one. That's a more specific one. Medicaid reimbursement for peer services, that's another state-to-state issue. As you know, many of the mental health peers get Medicaid reimbursement, and we're trying to get parity on a state level for Medicaid reimbursement of addiction recovery peer services. And then all across the country, we haven't talked about this, but recovery community centers are popping up everywhere, and we're trying to secure funding for those on a sustainable basis. And then finally, one of the things that we at Faces and Voices are very concerned about and are doing a lot of messaging and organizing around is this whole idea of health reform isn't going to do anybody any good unless people are enrolled. And the people in our community that haven't had access to the health system need to be targeted for enrollment. So they need the whole system explained to them and explain why this is something that would be beneficial to them and their health and their recovery. So we're developing enrollment strategies to engage the recovery community. We're doing targeted outreach to the recovery community, especially during Recovery Month. We're doing a whole campaign about enrollment and why it's important to the recovery community. As a piece of that, we're doing strategic communication and tailored messaging. We're creating venues and events throughout Recovery Month and beyond to conduct enrollment activities because enrollment starts on October 1st. Recovery Month is in September, so it's perfect timing for that. Where the whole idea is to how to not only enroll people, but then to connect them to the health system services that they need and deserve, and how to help them navigate through those sometimes intimidating or complex systems, and then how to keep people in the health systems once they're enrolled and once they're accessing those services. So gave you a little bit in a nutshell of a lot of the stuff that's happening right now, and how housing fits into a lot of this is that housing fits into health reform in a way that maybe no one ever thought about, that it's a service that is instrumental to early recovery, to supporting and sustaining recovery, and so it's something that should be thought of as a health benefit and packaged as such. So with that, I think I'll turn it over to Pat and Jason.
Thanks, Tom. Thank you very much. Now we have about 15 minutes or a little bit longer to take your questions and answer them to the best of our ability. Know that you can submit questions there in the Q&A box, which should be to the right hand of your screen. If we don't get to your question today, stay tuned. We're going to continue this discussion in different forms in the next couple of months. So we do have a couple of questions that have come in. Devin Reeves has a question and then a comment. One was, the comment was that I believe he was trying to click on the link that Dr. Jason provided at the end of his slides, and he wasn't able to get that link to work. Don't worry, Devin. If you look at the bottom right hand of your screen, there's an area that says 2 files. If you highlight the one that says position statement, that's the very position statement that Dr. Jason was talking about. So you should be able to highlight that, and then the download file button should be activated, and you can download that file or both of them. The other question that Devin asked is around fair housing, housing discrimination and NIMBYism that many of us face. And I love that question because it sets us up for the webinar that we're going to do on August 8th. Today's webinar is the first of a series of 2, and we're going to spend quite a bit of time on the 8th talking about that very issue. The other question comes from Matt, and let's see, let me pull it up here. Does anyone have data to what addiction actually costs the community? Can we put numbers on it? People listen to numbers and overdoses, et cetera, et cetera. You're right, Matt. I went and Googled. I cheated, and the estimated economic cost to society due to substance use and addiction is $559 billion per year. And I'm looking at drugabuse.gov, and this is data from NIDA. And it goes on to say that illicit drug use alone accounts for $181 billion in healthcare, lost productivity, crime, and incarceration. So you're right. There are big numbers, and I'm wondering from Pat and Tom being our advocacy efforts, how can we best utilize these types of numbers, this type of data, to further our cause?
Well, I think, as Matt said, they are very important numbers, and it's because of those numbers, one of the reasons that addiction is included in the Affordable Care Act, because when they were looking at health care costs, they realized that the cost of serving people with addiction in the ER were astronomical, and it really made sense to make sure to cover addiction care as part of the Affordable Care Act. So these are really critical numbers, and there are ways to localize some of these numbers as well. And as you think about your advocacy strategies, trying to get your hands on that data is really important. The National Survey on Drug Use and Health, there are some other resources. And Devin, for the next webinar that we have, let's post that as a resource where people can find out about how to break some of that down in terms of local and state cost in terms of untreated addiction. So we'll be happy to put that information together because it is critical and it really helps to make the case.
Thanks, Pat.
Sure.
I don't see any other questions. If any of our audience has a question, please post it there in the Q&A section. And if you think of questions later on, then make sure that you email one of us, and we can add that either to the 8th webinar, or we can answer that in a different form.
Well, Jason, thank you, and thank you for everyone who's been with us. We know this is a long time to be on the phone and really appreciate your commitment and your interest in this critical issue, and look forward to speaking with you a week from today. Thank you.
Thanks, Pat.
Uh-huh.